Few situations are as challenging for a therapist as being confronted by a suicidal patient.
Because the one thing you and I have to start working on now, and you should like this, is we have to start working on what sets you off to be suicidal.
The threat of self-destruction is only one of many extreme behaviors associated with perhaps the most perplexing of all psychological conditions: borderline personality disorder. How prevalent is borderline personality disorder? 1 in 4 psychiatric inpatients meet criteria. These patients experience intense emotional pain that is overwhelming and often incapacitating. In turn, therapists unable to effectively reduce that pain may also be overwhelmed by their own emotions and respond inappropriately to these patients, becoming either too distant or too close, which only exacerbates the problem.
It's one of the worst things about treating borderlines. It's very easy not to get along with them because they make you so mad. Then you have to deal with the reality that you have good reason to be furious at them, so you feel completely justified on the one hand, and you can panic on the other hand because they might kill themselves while you're not getting along. And so you somehow have to bring these two things together and be somewhat reasonable in how you approach things. So that's when you call a
Marsha Linehan is professor of psychology and director of the Suicidal Behaviors Clinic at the University of Washington in Seattle. Dr. Linehan has been researching the complex nature of borderline personality disorder for more than 20 years, trying to understand why these patients have such difficulty overcoming their impulsive and self-destructive behaviors.
The people who meet criteria for borderline are people who often are very difficult to treat, both because we don't have treatments that are effective and because people who meet that criteria are just inherently difficult to treat.
Recently, Dr. Linehan published a book based on her findings. The book presents a treatment model for borderline personality disorder that is based on cognitive behavioral therapy. But Dr. Linehan has added to that model, creating a treatment approach she calls dialectical behavior therapy, or DBT. Data from her clinical studies indicate that DBT is effective in the treatment of these patients, outcome that has generated a great deal of interest from the therapeutic community.
I'm very happy to be here, and thank you for inviting me. I'm going to talk about some research that I've been doing. Some of you have perhaps read about it or seen some of the data, and I'm going to present sort of
As a result of her success treating borderline patients, Dr. Linehan is often asked to speak about her work to professional and patient groups, such as this psychiatric grand rounds in New York.
A lot of people now think of me primarily as a researcher in borderline personality disorder. I must tell you, I think of myself, my kind of self-identity is not that. My self-identity actually is a person who studies and treats and is interested in suicidal behavior.
Although her initial research focused on women with a history of suicide attempts, Dr. Linehan and others are studying the effects of DBT on other behaviors, such as substance abuse and eating disorders. This program will cover 4 primary areas, including the nature of the disorder, factors that may give rise to it, why these patients resort to self-destructive behaviors, and an introduction to dialectical behavior therapy. Then, at the conclusion of the program, Dr. Linehan and Dr. Alan Francis, chairman of the DSM-4 task force, will discuss issues and concerns therapists have about treating these patients.
The basic problem with the term borderline is that the meaning isn't very clear to anybody. And the meaning originally came out of theoretical position on people who have this disorder. And so the term has a lot of meaning in a particular theoretical approach.
The term borderline personality disorder actually has its roots in psychodynamic theory. These patients were thought to be somewhere between neurosis and psychosis, on the borderline, so to speak, between these two mental states. To illustrate Dr. Linehan's approach, actual patient interviews will be used. However, to maintain confidentiality, the images have been electronically altered.
So tell me, what do you want out of therapy with me? I mean, what are you doing here?
I want to get better.
Well, what's wrong with you?
I'm a mess.
How so?
I don't know. I just can't even cope with everyday life right now.
So what does that mean exactly?
Well, I don't know how to handle money, and I don't know how to handle relationships, and I don't know how to handle myself.
So from your perspective, the problem is that you don't know how to do things.
Yeah, I'm sick of this stuff. I really am. You know, and I'm backed up against a wall. Either I need to do this or I need to die.
I am a mess. I can't cope with my life. I don't know how to handle relationships. I need to die. Complaints typically heard from patients that meet standard criteria used to define borderline personality disorder, such as those found in the DSM-4. However, in developing her model, Dr. Linehan has rearranged the 9 DSM-4 categories into 5 that she finds more clinically useful. These are emotional dysregulation, characterized by emotional responses that are highly reactive, along with episodes of depression, anxiety, irritability, and anger. Interpersonal dysregulation, including fears of abandonment and relationships that are chaotic, intense, and difficult. Behavioral dysregulation, marked by extreme and problematic impulsivity, such as profligate spending sprees, indiscriminate sexual conduct, reckless driving, binge eating, self-mutilation, and suicide attempts. Cognitive dysfunction, including brief, non-psychotic depersonalization, delusion, and dissociation. And dysregulation of the self, with complaints of feelings of emptiness and problems with self-identity. Dr. Linehan's research on DBT is an ongoing process. Therefore, therapy sessions are always monitored to observe the behavior of the therapist and ensure adherence to the treatment manual. The range and complexity of these beliefs and behaviors may be a contributing factor to the negative image associated with this patient population.
A lot of people can't stand people who meet that criteria. There's a lot of prejudice towards people who meet that criteria. And so before you ever show up wherever you're going, if people think you meet criteria for it, they already don't like you before you get there.
The question is whether you're saying now that you refuse to keep the agreement, because we have this battle all the time.
So that's the main reason patients don't like it, because they know that there's a lot of prejudice. And they're right about that. There is a lot of prejudice. And mental health professionals often don't want to work with people who meet criteria, refuse to work with people who meet criteria, etc.
However, Dr. Linehan believes that those attitudes can be overcome through a clear understanding of the factors that give rise to this troubling disorder.
So I started and spent a lot
In
of
Dr.
years
Linehan's dialectical approach, there are 2 important elements that appear to be involved in the development of borderline personality disorder. One, biological, and the other, environmental.
What I believe is that borderline personality disorder, as its core, is a disorder of the emotion regulation system. But what it is an emotion regulation dysfunction. Now, it's important to recognize what I mean by that.
According to Dr. Linehan's theory, this emotional regulation dysfunction comes about as a result of a combination of emotional vulnerability, that is, overly sensitive responses on the part of the patient, and an inability to modulate the resulting emotions.
In a sense, I think of it as a temperament disorder, which is you've got an individual who comes in with difficulty regulating, especially negative affect and possibly positive. The fact that I'm saying it's biological doesn't mean I think it's genetic. There's not actually, the data is not overwhelming that there is a genetic link, although there's a little bit. But it could be intrauterine factors, which certainly can have an effect on later functioning. And it could be some sort of trauma, especially head trauma, at an early stage in life. Okay, so I think there are a lot of ways to get biological dysfunction. And I believe that there is a biological dysfunction. And so what you've got is this group of people who, if you read the developmental literature, are like the slow to warm up child or the inhibited child or the difficult child that the developmental people talk about, okay? So it's this child who's cranked and can't regulate affect well, okay? Especially negative, they can't regulate. Now, that would answer the whole question if it wasn't for the fact that if all those people were borderline, we'd be overrun with them. Okay, so it can't be that that's all there is. Okay, there's got to be...
In addition to this biological predisposition, Dr. Linehan believes certain environmental factors are also involved.
What kind of environment is the environment that doesn't fit with a difficult temperament or a inhibited temperament or a temperament where the individual has trouble regulation? The theory is that the key environmental characteristics, what I call the invalidating environment.
The defining element in an invalidating environment is that it pervasively communicates to the individual that his or her private responses to events are invalid, inappropriate, or incorrect.
In an invalidating environment, all problems are viewed as motivational problems, that if you just try hard enough, want to do it, you can pull yourselves up by the bootstraps. It's kind of the pure cognitive therapy environment. You know, if you just think straight, you feel better. If you wouldn't distort, you'd be okay, etc. Our whole culture largely has this, in some families more than others. The primary reason you don't learn how to effectively regulate emotions in an invalidating environment is because the failure and the difficulty in regulating is never taken seriously.
The need for validation has particular importance for these patients. A majority report incidents of sexual abuse in childhood, a typical invalidating experience that is often dismissed by others. As a result, the patients do not learn to trust their own responses to events and search the environment for clues as to how to think and feel.
Now, this happens consistently and constantly with people with emotion regulation disorder. What happens all the time is other people say, calm down, quit distorting, you're exaggerating, quit being so upset. I mean, when's the last time you said that? Even I, who have this theory, say that kind of stuff. I mean, you know, I think that we all do it because it's so pervasive in our culture, which is fine if you can do it. I mean, I don't have any problem with this sort of culture, except that it's not good for this sort of person.
The point is that the interplay of emotional dysfunction and an invalidating environment results in an emotional instability, which in turn leads to the interpersonal, behavioral, cognitive, and self-dysregulations that characterize borderline personality disorder.
I'd like for you to think of some situations in your own lives that we can practice with.
This group of patients and family members are learning how to improve the quality of their interpersonal interactions.
I understand that maybe you're interested in my well-being, and I really do appreciate it, but I really feel overwhelmed.
This role-playing exercise puts Kim, a former patient, in precisely the kind of situation which in the past would lead to an emotional crisis. Only now, she has learned how to respond in an effective rather than in an extremely ineffective way.
I think the biggest thing that it's helped me with is this whole idea of feeling one thing and just feeling like I have to act on it, and knowing that somehow I can feel this way and act differently. I understand. Those are things I could never do before, and every time I would get into situations where I'd either have to say no or make a request, I would freak out because of the emotional state or because I would just be so angry at myself for thinking I could say no or for thinking that I could ask for something. And I really found that it's particularly helpful in me organizing my thoughts, but also in me feeling okay about myself, whether or not I get what I want.
Kim has learned that she can respond to emotional situations without resorting to extreme behaviors. But the question remains, why do these patients go to such extremes, even to the point of killing themselves in response to emotional crisis?
The function of borderline behaviors are to regulate affect or they're a direct consequence of dysregulated affect. They're so effective that it's almost impossible to get the behavior stopped. The problem with stopping suicidal behaviors is they're almost made in heaven for affect regulation. First of all, of course, almost everyone thinks if you're dead that you feel better. Okay, so if you talk to borderlines who want to be dead, inevitably they will tell you something along the lines that they're actually going to feel better. Okay, either they won't be here so they won't feel anymore. It's kind of like dissociating in sort of an extreme way. Or they're going to heaven or something, or they're seeing their relatives or something like that. Now, I have not seen it in the New York Times yet, so I don't know if that's true or not, how it really happens. And in fact, you just heard the beginning of the therapy for that. Okay, the first and major thing we do is shake up a belief that things will be better if you're dead.
I mean, I don't think I really want to kill myself, but I don't see anything any better than it was the day that I tried to kill myself.
I mean, trying to kill yourself just sort of offhand doesn't usually solve problems.
I just think that I feel like I have to, you know. It's not, I don't think it's really even a moody thing. I just think it's when I feel like there's no other choice. I just say, well, you know, there's no other choice, so I do it, you know.
Okay, so back to what you want out of therapy. Now, one of my goals that we need to get agreement on is kind of independent of what your mood is, that you won't try to kill yourself again. Now, the question is whether you agree to that.
I agree with that.
Okay, now, how does it work? Overdosing is marvelous for affect regulation. I mean, all of us have said, you know, I'll feel better tomorrow. Let me get some sleep. A good overdose, a really one that works well, puts you to sleep. And most people feel better after some period of time sleeping with some sort of drugs. Cutting and burning are very effective, but no one actually understands why. I mean, there are a lot of sort of biological theories, and the behaviors, of course, say no, it's probably this, but nonetheless, no one's really got the data goods on that. We don't really know why it works, but everybody who's worked with these people knows you get a person, especially with anxiety and anger, is best on those two emotions, I think. But a little cutting, and a person feels a lot better. And you hear this repeatedly, and I think everybody agrees that the phenomenon occurs. We just don't know why it occurs. Now, the next way that it works you might not have thought of, but if you understood emotion modulation, and there's actually not a lot of work, but some research on emotion modulation, and what humans do to modulate emotion, it turns out that one of the main things that humans do, and one of the things, in fact, you have to be able to do to modulate emotions, you've got to be able to control attention. And if you cannot control attention, you cannot control emotion, because distraction or focusing on something else is a very effective affect regulation strategy, as it turns out. And many borderline patients often cannot control emotion. So it turns out that regulating affect requires the ability to regulate attention, among many other things, but that's one of the things you have to be able to do. Now let's think about jumping from high buildings, trying to drown, and a few of those things. You have to agree that they focus the mind. Okay? They definitely have that effect. So they regulate affect, often by focusing on to something else, which then becomes a major thing sometimes, especially if it happens on an inpatient unit. It can really take up everyone's time and attention away from whatever this other was. And parasuicidal behavior also often regulates the environment, and the environment's often the source of the negative affect in the first place, or the precipitant of it. So, you know, we all know that lovers come back, husbands come back, people put you in hospitals. In Seattle, we've actually gotten some hospitals to put you out if you do that kind of stuff, etc. So the environment changes. So it's very functional behavior, very effective behavior. It only has one drawback, which it's got long-term negative side effects. And if it wasn't for that, one could be in favor of it. But the recognition of how effective it is what alerts you to the trouble you've got trying to stop it, which is why it's extraordinarily difficult.
Dr. Linehan comes from a cognitive behavioral background. In formulating her approach to understanding borderline personality disorder, she built upon the precepts of the existing theory. For example, standard cognitive behavioral therapy is a technology of change, that is, changing behavior through learning and experience. Dialectical behavior therapy goes a step further in emphasizing that patients fully accept themselves, their emotional status, and their environment as they are, an approach that Dr. Linehan defines as radical acceptance.
You're going to see why I moved away from what I think of as standard behavior therapy. I realized that I had to somehow blend into the treatment acceptance. Not only acceptance of the individual, but acceptance at a radical level. In other words, true acceptance. Not as many of the people in the acceptance is a big word now. You may not know that. In psychiatry it may not, but in psychology it is. But many of the acceptance people are sort of acceptance for change. In other words, they're not really into acceptance. They're into acceptance as a strategy to get you to change. And so it's really change-oriented. But I started thinking maybe we really need radical acceptance, true acceptance. So I started looking around for who knows anything about that. And it's very interesting. You would think Western psychology and psychiatry would have it, but they actually don't. They mostly have this acceptance in order to change stuff. And especially Rogerian, which is sort of the grandparent of acceptance, their acceptance is that you have the potential to be somebody, but you're not yet. Okay, but I knew that wasn't going to work out well to try to send that particular message. So I figured I needed something, and what I finally did was I went to Eastern psychologists, and I went over to Buddhist psychology Zen practice. And I essentially ultimately dropped the Buddhist part of it, kept the Zen part of it, and tried to learn, because those are the people, spiritual people in general, are the ones who talk acceptance a lot. So I figured maybe they knew something about it. And so I went and actually studied, and still do. And that's where I ended up picking up most of the acceptance, the radical acceptance strategies, that I then brought back in and put together with the behavior therapy. But I knew, especially not in the early 80s, I couldn't go around saying I was doing Zen behavior therapy. This was not going to work out professionally. And so I figured I need something else, and so I needed a theory that could put the two together and get one word, get it from two to one. And that's when I found dialectics, dialectical philosophy. I went to that, and I brought that together and brought that in, and that's the house that the whole therapy sits inside of, so to speak. It's the philosophical frame. And then it's turned out all by itself to be a driving factor in the development of the treatment. And the key thing to know about this, is that dialectics, the whole focus is on the resolution of polarity and tension and the movement towards synthesis.
Dialectics is a process of change. An idea or thesis generates and is transformed into its opposite or antithesis. The tension between these opposites gives rise to a reconciliation or synthesis. In borderline personality disorder, the patient gets stuck between extremes, unable to move toward synthesis. Dialectical behavior therapy emphasizes that patients accept themselves and at the same time make attempts to change.
We've got to figure out a way to tolerate bad things without harming yourself. So let's figure out all the things you tried. Then we have to figure out some other things, since those didn't work.
Tried talking it out with people.
And what happened?
Failed.
Okay. Did you ever try radical acceptance?
What's that?
You just give yourself up, sort of a situation. You just accept that it ain't going to happen. And you're going to have to cope in some other way. Because all of us run into boulders on the path. Our life is like walking on a path, you know. We all run into boulders. And it can't be that nothing else can help. There's got to be more than one way to get everywhere. Those of you who've worked with borderlines know that there's a lot of polarities. There's a lot of what the analysts call splitting. I don't use that term. But a lot of tensions and extremes on both sides. And that not only goes on, not only do the patients do it, but I've come to realize that the therapists do it also. And both of them tend to often get into black and white, rather extreme, often inflexible, reasonably rigid sorts of behavior patterns
and that dialectics is really geared to dealing with that. And it's the balance of acceptance of change that's come to define the therapy and is the reason for moving away from standard behavior therapy. It's this acceptance and balance.
Balance is the hallmark concept in dialectical behavior therapy. For example, supportive acceptance is balanced with confrontation and change strategies.
So I think it's not actually the pain that's the problem, but it ends up focusing as if it were the pain when it's not the pain. It's the sense of being invalidated and the sense of not being cared about. That's my guess. What do you think?
Mm-hmm.
But the problem that we have to solve is how to be in a situation that you feel is unjust without having to harm yourself to solve it. You open to that?
Yeah.
In addition, active problem solving is balanced by a corresponding emphasis on validating the patient's current emotional, cognitive, and behavioral responses.
You see, what I think is happening is that when you're in a lot of pain and you feel either not cared about or not taken seriously, invalidated, that's what sets you up to hurt yourself. And I also want to die. And that what we need to do is figure out a solution to that problem so that there are other ways to get out besides hurting yourself or trying to kill yourself.
And stylistically, DBT balances a straightforward, somewhat irreverent attitude on the part of the therapist with warmth, flexibility, and responsiveness to the patient.
You know, it's really hard for me. I've been going through this since I was 11 years old. I'm sick of this shit. Either I need to do this or I need to die. Those are my two choices.
Well, why not die?
Well, if it comes down to it, I will.
But why not now?
Because this is my last hope. Because if I've got one last hope left, why not take it?
So in other words, all things being equal, you'd rather live than die, if you can pull this off.
If I can pull it off, yeah.
Okay. That's good, though. See, that's going to be your strength. We're going to play to that.
Patients with borderline personality disorder present a significant challenge to therapists.
Are you feeling like killing yourself right this minute?
In addition, this complex and confusing disorder has significant impact on family members as well. But looking at the troublesome beliefs and behaviors associated with borderline personality disorder from a dialectical perspective may help raise the level of understanding about this seemingly intractable disorder, and in the process, improve the lives of these patients.
Many of the patients that we see have lifetime histories where the miserableness of their lives, the desperation of their lives, is only paid attention to when it's accompanied by being suicidal. In other words, many of the patients have experiences where they only get attended to if they say they're going to kill themselves. I'm trying to change the pattern, and I'm trying to teach the patient that they can be attended to without having to get suicidal. I'm telling you something, listen to me. If you don't kill yourself, you're going to make it. You're going to get out of hell. You're going to get out of here. It's not always going to be so bad. Life is not always going to be so painful, and you're not going to hurt so bad. You're going to get to be like a more normal person who has a life that's worth living. That's going to happen to you if you don't kill yourself. You work too hard, you're too bright, and you're too capable not to get there. You're going to get out. You just have to keep yourself alive.
Marsha, how do you get started in working with one of these people?
Well, from my point of view, one of the most important things to do is to structure the treatment. And so what I've done in thinking about treatment is divided or looked at treatment in terms of phases. So I think there's a phase 1, a phase 2, and so on. And the first phase is what I call the pre-treatment phase. And that's the phase that some other people call the contracting phase. But during the pre-treatment phase, that's where you've got to do your assessment and make sure the person actually meets criteria for the treatments that you're doing, or find out what they meet criteria for. So I recommend to everyone that you, with all patients, even if you don't think that they meet criteria for borderline personality disorder, that you assess for borderline personality disorder, even if you don't assess for much else in a structured way, because many individuals who ultimately do meet criteria for the disorder don't appear like they
meet criteria for the disorder, and in fact may be functioning at a much better level than they will subsequently.
How do you form the treatment alliance?
Everything about therapy forms a treatment alliance. If there's suicidal behavior, I always focus on that first. If you've been kicked out by every therapist and no one likes you, no one wants to work with you, and you're not suicidal, that would be second, or that would jump to first. And so I begin with by saying, first
So
of
the
all,
most emergent behavior first, but then therapy defeating behaviors second?
no, suicidal behavior and life-threatening behaviors first.
First, right, okay.
Okay. So included there is suicide crisis, threatening to kill yourself, trying to kill yourself, and any behavior where there's intentional self-injury. And the reason that's important to do first, because a lot of people argue with me on this and say, no, you should skip that. But the reason, for example, we'll say, let's not deal with cutting first. A lot of therapists say that, and patients almost always say that. And the reason I never say that is because I think that if a person intentionally tries to harm themselves, that's the exact opposite of the goal of therapy. That's the most incompatible behavior with therapy that I can think of. And so as a therapist, it seems to me I couldn't possibly not target that first. So what I say to the person at the beginning of therapy, first we find out about those behaviors. And you either get that from referral, or you knew about it from whoever called you, or the patient tells you, any of the above. And then what I say to them, I say, listen, the question is, do you want to stop that behavior? Would that be a goal? Are you willing to agree that that would be a goal of therapy? And if they don't want to stop it right this minute, I sort of lay off and I just suggest that at least would that be the goal? Is that what we'll work towards together? Are you willing to agree to that?
Suppose I say, no, I feel too bad, I don't want to be bothered with anything.
You don't want to be in therapy at all?
No.
Okay, if you don't want to be...
I'm forced here.
You're being
The
forced here?
cop brought me here, and I really don't want to be here at all.
Okay. If that happens, then that's almost the definition of pre-treatment, because treatment requires this collaborative agreement. So then all of therapy focus, I do nothing except discuss with you the pros and cons of the current life, which I usually point out is the life of chronic. And I point out, you can be a chronic all your life, that's fine, or you could be in therapy and not be a chronic. And getting that initial agreement to therapy is the first task, and I don't do anything else. The average person who comes in can see that this particular way of running a life is not working. So then all you have to say is then you have to choose between this life that's not working or some other possible life. And that's the whole focus, and that's all we really do in therapy.
And the person keeps saying things like, the reason it's not working is because she's done that to me, or he's done that to me, or
Yeah.
I had a terrible early life and I can't get over it.
Yeah.
How do you get them to see it as something they can change?
Well, they only have two options. This is what I would say to them. There are only two options. You either accept it the way it is and stay miserable the rest of your life, or you make an effort to change it. And I can't guarantee you can change it. Who
You can't expect the world to change, so that means you're going to have to.
Well, you could wait around for the world to change. I don't have any problem with that. It just hasn't changed yet. It probably won't change. You could wait for it to change. But on the other hand, you could see if, while you're waiting around for it to change, you could be a little bit happier. And is that an option you might consider? And we could work on that.
Well, a really important part of establishing this alliance is getting the patient's attention. And as you know, you're one of the most compelling people in the world. The question is, can everyone do this? Are some people better at it than others? And what's your advice to those people who don't naturally compel other people's attention in the way that you do?
Well, that is probably one of the most common comments that's made about this treatment, is people saying, isn't this just your personality? Isn't this just you? So it's a reasonable comment, except for the following. I have trained a lot of people in doing this treatment now. I've trained a lot of graduate students, so that kind of people becoming doctoral level, but a lot of case managers and a lot of master's level therapists. And my experience is that it isn't a personality characteristic, that almost anybody can do it. Obviously, some will be more comfortable. But that part of the compelling nature of it is the approach itself, not the personality style.
You've probably worked more than any other therapist in the country with these problems. Based on all you've done and all you know and all you've lived through and all you've experienced, what's your advice to the rest of us?
I think that therapists have to believe in their patients. That you have to find
the strength and the capability that's there. And then you have to amplify it. And that you have to believe that you can do it. And then I think that you have to believe in yourself. And I think you have to find the capability and effectiveness that you have within yourself, which I'm convinced that therapists have. And you've got to find that, and you've got to amplify that and bring that out also. And you've got to believe in both. And then, when you lose all your faith, which, take it from me, everybody does, you've got to have someone who will believe in you. And you've got to talk to them. Then you believe in yourself again, you'll believe in the patient again. You'll lose your faith in the patient, you have got a colleague who will. You lose it in yourself, you've got a colleague who will. But ultimately, there's got to be this circle of believing. And I think that the data show that if you do this and you use the available effective treatments, you can make people's lives better.
In addition to this program, there is a companion videotape, Treating Borderline Personality Disorder, the Dialectical Approach. These programs provide an overview of Dr. Linehan's approach to borderline personality disorder. The principles of dialectical behavior therapy are addressed in far more detail in Dr. Linehan's book, Cognitive Behavioral Treatment of Borderline Personality Disorder, also available from Guilford Publications.